All right, back up so I can see. Say it again.
I think you hit stop recording, not start.
You are wrong. All right. So we're going to go through neurovascular emergencies. This is really just a summary of seizures and strokes more than anything. Like if you end this lecture and you're like, what's a seizure? You're in big trouble, right? So we definitely want to make sure that we can kind of pull those two things away from this lecture. We're going to go through some anatomy. As I always say, anatomy is best learned at home, but I can kind of point some stuff out for you here. If I'm being honest, I think you're probably only going to get one, if any, questions on something like a prefrontal cortex or what is the parietal lobe, blah, blah. So I'm not teaching you to memorize that stuff simply because I think you're going to get asked a direct question on it. But I think the knowledge of those things is really going to help you answer. Like, for example, you've got a guy that's fallen and hit his head. He's complaining of diplopia. What should you suspect? Well, I'm not only thinking that he hit his head, I'm thinking he hit it so hard that he's got double vision. And I know specifically that the occipital lobe is what affects his visual processing and memory. And so now it's like, okay, I didn't ask you a question about that, but because you can kind of put that together, it's really going to help. Now, we've talked a little bit in the past about the peripheral nervous system simply because we've talked about the sympathetic and parasympathetic, at least in passing. What we're going to be spending a lot of our time talking about today is the central nervous system, which is just the brain and the spinal cord. So like I said, even though there is a lot of stuff to know and discuss here, if I'm being honest, I don't even think that it's important to differentiate afferent nerves, though I know my girl Shannon definitely has in A&P. Holy Lord. I can make it simple for you, really, but I'm not gonna, because I don't care if you know it. So we're just gonna skip on past that stuff. And again, specifically today, we're gonna be largely, not only just talking about, oops, wrong computer, not only talking about the central nervous system specifically, we're basically only talking about the brain today. So we'll just go through a quick review of what these three things are. Part of the reason, I don't think I am going to be able to not go to the screen, find a way to lock that, but is trying to quickly and easily differentiate what these things do. Remember that the vast majority of your brain is made up of the cerebrum. It's the big part. That the cerebellum is often referred to as the small brain. It's that little chunk there on the back, not to be confused with the occipital lobe necessarily. And that the brainstem largely governs life functions, though we don't have to get hyper-specific on that. You see what I mean here in this baby poop mustard yellow? That this is not the occipital lobe, this is the back of the cerebrum. Now you'll notice as I kind of flicker back and forth here, that most of these places that involve these sense and sensations also store the memories of those senses and sensations. The reason why we've got this added facet here is because we really need to think of a stroke as hypoperfusion of the brain. And if I get hypoperfusion of my left hand, for example, maybe I can't give a thumbs up like you know I need to, right? If I hypoperfuse in the brain, you might ask the question, well, what does it affect? And the answer is, well, where is it hypoperfusing? Because if you are hypoperfusing in that small part of your brain that remembers the feeling when you put a 9-volt battery to your tongue, and you hypoperfuse and where that is stored, you will no longer have the knowledge of what that feels like. Why? Because that part of your brain died. And so you can really draw the conclusions. Later we'll talk about the FAST scale, Cincinnati scale, and you can actually kind of point, if you knew the brain well enough, to where they're hypoperfusing based on their presentations. Now, you don't need to know exactly where and why that's happening, but you do need to know when to suspect that it's happening. But I remember talking to a doctor once, and I brought in a patient, and I said, you know, I don't know, doc, I took him here because it's a stroke center. The guy had numbness and tingling around his left arm. It wasn't positive for any stroke signs that I know, but it was weird, you know? And the doc said, well, what if he was having a stroke in the sensory part of his brain, not the motor part? And I was like, okay, yeah, all right, you know? So I'm not trying to say that like if a person has a symptom of any kind, it could be a stroke. But what I'm also kind of trying to say is if a person has a symptom of any kind, it might be a stroke. That we have to kind of rule in and rule things out because the brain, if you didn't know already, controls a lot of your body. The cerebellum, I think, largely summed up. And careful when you Google this or turn to one page and then the other, you'll find all kinds of words surrounding these things. This is what I care. This is definitely one of those moments where I'm like, hey, study the slides here. I think it's the fastest, easiest way through this stuff. Know that the brainstem controls a lot of our basic functions. We're going to go a little more in depth today, but we also have to make sure that we know that it not only controls our respiratory rate, but also the regularity, right? The breathing patterns, and that it helps us maintain consciousness in a myriad of ways. In summary, the brainstem does a lot of heavy lifting. That water's special good today. And as a reminder that that's part of the reason I've even considered, now that we don't have the National Registry kind of governing our patient assessment, I can throw out the old book and just come up with my own perfect evaluation. Well, I did. It's a lot like the registries, I don't know how to appropriately teach you to assess that isn't fundamentally going through ABCs, because I need to know, is your brainstem functioning appropriately? Because the brainstem is essentially like one of the last neurological rungs on the ladder. If you've got decreased respiratory rate or an irregular pattern of some kind, I know that you don't just have special high-minded brain problems, you got nose-picking monkey problems. Like the parts of your body designed not to be good at chess, but just make sure you eat a red berry to keep walking, like the fundamental parts, something's wrong with it if your respiratory rate is off. That's where this is, Now, just over here on the brainstem, we have the hypothalamus. All I care that you know about the hypothalamus is that it's a thermostat. That if a person has a fever, their hypothalamus is either working to help kill a virus by overheating you, or not working and running amok and overheating you. Like, we're not really sure whether sometimes your hyperthermia or febrile patient, whether it's the cure or the cause of the issue, we're not entirely sure, but we should now be able to point to the fact that it's the hypothalamus that's the problem. Now, we have to be careful here, especially with peds. What I don't want you to say is, on a day like, let's say we're in this room, right? Let's say your ambulance is on and it feels like this in this room. It's, I don't know, what is it, like 42 degrees in here? Whatever, sure does feel like it. But the point is this: if I've got a patient who's got a tympanic temperature of 102 degrees, they're pediatric, and then you say, hey, don't cover them with a blanket because they're overheating, I would say, yeah, but if we go into a room where it's really cold, that can also be a problem. So what I'm not trying to say here is just because people are overheated, they shouldn't be covered. I'd say, well, then put a sheet on them, not a blanket, because we just want to help them kind of thermoregulate, right? Because when you're sick, your hypothalamus may not be working as effectively as it should be or be able to thermoregulate. And so helping by covering you with a sheet can be important. And we'll talk later, because specific with pediatrics, if they change temperature too fast, they can have a seizure. Now, I don't know that you need to know this, but I just think it's so super cool. This is one of those situations like when I tell a girl who, her name is Emily, and I say, oh my God, it's my favorite name. I want to get that tattooed on me. And she's like, oh, is your wife's name's Emily? And I say, no, it's Grace. I don't even know an Emily. And then they always give me that look like you are a robot, alien, psychopath. Okay, this is kind of one of those moments, but I like the idea that like the sun emits light, that it hits the bear in the woods and then goes into my eyes. Without the sun, I don't know there's a bear over there. That's how light works. Because of that light entering into my eye and therefore optic nerve, that electricity is going into my brain, into my occipital lobe, and is giving me that image of a bear. And it's tapping into my memory of a bear based on the visual cortex. Now, because of other parts of the brain, I remember when my buddy got eaten by a bear or something, and so the light bounces off the bear, it goes into my eyes, it hits my brain, and I'm like, oh, I gotta go. This is a problem. How I go is essentially through the hypothalamus. Can't turn it off. The hypothalamus is essentially turning the electricity running through my brains into the hormones in my body that get me to go. It's where essentially the light becomes electricity in the brain, and then it becomes hormonal. It's saying, hey, legs, get legging. Send impulses, send adrenaline, send da-da-da. There's a lot of very, very narrow steps in there.
So is the pituitary exclusively for the sympathetic nervous system?
I don't know.
Okay.
If somebody knows, they can weigh in. I don't know enough about it. I know that it involves, there was a time I knew, but it's known as the master gland and incorporates a myriad of first step hormonal releases, like hormones that release other hormones kind of thing. I don't remember. There's a whole chapter on your book, or sorry, a portion of your book involving dermatomes. You don't need to know about that. The idea is essentially that if your spine was broken at a certain area, we could tell where it was broken, whether or not you had sensation on this finger or that finger, okay? So I guess I'll just say this. I don't have any questions on it on a test. I don't think it profits you much as an EMT, and I think it can greatly mislead you in many ways. So don't worry about dermatomes. But let's talk a little bit about neurons, starting first with just this isn't a neuron. What kind of cell is this? It's a red blood cell, or erythrocyte if you nasty, right? Now this isn't a cell, but this is what hemoglobin looks like. And of course our erythrocyte is transporting hemoglobin. Or at least it's a representation, kind of looks like a virus, but if you've got a normal erythrocyte with a series of hemoglobin on it, and that's how we get oxygen. I breathe and my liver works. How? Well, the oxygen goes into the red blood cell, it attaches to the hemoglobin, it gets dropped off at the liver and back and forth, right? What's going on with this red blood cell? Sickle cell. And we get sickle cell due to a dysfunction of the hemoglobin. When hemoglobin kind of lines up in a strain, forming rods instead of all these dots, it causes our erythrocytes to be sickle-shaped. What kind of cell is this? No. These are going to be nucleuses in a cardiac striated cell, right? Now, you don't need to know about the histology of these cells, but all I mean to say is, like, do you see how varied all of these things are? But we just kind of largely say red blood cells, heart cells, myocytes, and erythrocytes. When you look at a neuron, just know that this is a neurological cell. It's not as crazy as it maybe first seems. We're more familiar with red blood cells because we talk about them more and you don't have to push too hard to see them, right? But a neuron is just the neurological or neurovascular version of a heart cell or a red blood cell. All right, let's get to the meat and potatoes. Now, I was really proud of the book. I think this is the first time that I've seen something where the topic they were talking about was not the #1 killer in America. If you asked me what the #1 thing that kills Americans is, I would have probably said, well, heart disease and trauma. Apparently cancer is way up there. And probably the reason that Mr. Fearon doesn't suspect cancer is way up there is because there's usually not a mystery there. Like, we don't get dispatched to an innumerable amount of cancer patients because we know why they feel bad. It's the cancer. Now, I will say, I've run a whole bunch of calls where it's like I show up, guy can barely breathe, I put him on oxygen, and I say, hey, what's his medical history like? And they're like, well, lung cancer. And I'm like, oh, okay. And they're like, yeah, but he needs to go to the hospital. And I'm like, I don't mind taking him. But he's got lung cancer. And has anybody explained to you what lung cancer is? Because I don't think, okay, let's go. Absolutely, let's go. So it's not unreasonable to think that you're going to get cancer patients that say, hey, I know I live with cancer, but today I'm really bad. And it's possible they go to the hospital. Cancer is now eating away at his lungs. It fills his lungs up with fluid. So they go to the hospital. They drain that fluid. He stays in there for a month, and then he goes home. It's completely reasonable for cancer patients to have acute emergencies, for sure. But I rarely encounter them, I would say, because it's just, there's no real mystery there. We know what's going on, right?
Do you guys typically still always want to go?
If you're getting dispatched to the house of a person with cancer, they want to go, and you should encourage them. Put simply, they're like, I know I have metastatic brain cancer, but this is a new symptom. I'm like, I know, but like, You're going to get a lot of those, but we got to take them anyways because we got to make sure that it's not something that we can't fix. Stroke, CVA, cerebral vascular accident, these are all synonyms. It's a heart attack in the brain. We have to figure out the types, a reminder about ischemia versus infarct, what exactly transient ischemic attacks are, and then just how to identify these things and identify their mimics. Now, we've talked a decent amount about the aorta being one of the largest, or the largest artery, rather, in our heart and how it comes directly off our heart. But I just wanted to show you a picture. Like, remember then, essentially, we've got arteries going all the way up our necks and into our brain. They're exchanging nutrients and oxygen across capillaries and then returning down veins that are not included on this picture. There are big arteries. In fact, you can see there in the center what's called the circle of Willis. It's just a serious network of arteries. I can remember, I tell you about the woman took a 30-30 in her mouth, boom, and I grabbed her brain. Her brain didn't slide through my hands because of the arteries, because it was like a net in there. Totally wild. Yeah. I was holding her brain, my dear. Yeah. Yes, she passed away. I gave her epi, dude. I kept that heartbeat. No, she was, can't put the brain back. Not when it's in pieces. Okay. So a CVA, or a cerebral vascular accident, is reduced blood to the brain. This is hypoxia of the brain. Could you have a stroke if you get a blood clot in a cerebral artery? Yes, you could. Why? Because blood is not getting through, therefore oxygen and nutrients are not getting through, right? Could you have a stroke if instead of a clot, it's a burst vessel? Yes, you could. Why? Well, for the same reason, because blood's not getting where it needs to, which means oxygen and sugar isn't getting where it needs to, right? Could you have a stroke because of a lung problem? Could you have a stroke because of a heart problem? Could you have a hypoxic brain event without ever having a clot or a burst cerebral vessel? Yes, you could. Why? Because if you're not getting enough oxygen, then you're hypoperfusing in the brain, and that's probably a little misleading to call it a stroke off the bat, but that's what it is. I say all that to just say, remember that a stroke isn't just you saying, well, is it a clot or is it a rupture? No, what I'm asking you is there brain tissue getting enough nutrients and oxygen? Because if you've got a guy who's bradycardic at 30, and it should be around 70, let's say, for an adult, it's not just his heart, and it's also not just his brain, it's his entire body, right, is becoming hypoxic. So low oxygen and low glucose. This starts as ischemia, it ends as infarct. What's the difference between ischemia and infarct? Injury versus death. And much like the heart tissue, once these cells die, they do not come back. And so it's not uncommon at all to have people who have developed a deficit during a stroke and now live with that deficit. Do you remember what I say about refusals? You don't get people to go because you tell them they're gonna die. I do think you should do that. How do you get people to go to the hospital that don't want to? You tell them they're gonna live, but they're gonna live with dysfunction or disability. That's what gets people to go. I show up, a guy's got a facial droop, and I say, hey, you need to go to the hospital. He says, no, I don't want to go, I don't want to live, my wife left me, I don't got a good job, I want to die, da da da. I say, okay, here's the thing, I'm not so sure this thing will kill you, but look in the mirror. I think you live the rest of your life like this, struggling to pick up a spoon, spilling all of your stuff. Look, we can have a conversation about whether or not you should die, but today let's just have a conversation about how you're probably going to live with this disability. That'll get them for sure. Time is brain. You lose 2 million brain cells per minute. That's not a test question, but it's just kind of in part on you. Like, if you're having a stroke, you're losing a lot of brain cells. Some of us don't have that many to spare, right? Now, I will say this. I heard Mr. Dennert say this, and so I ran into the math of it. I wonder if I can... It's a little misleading. 2 million is a big number, but when you have 86 billion brain, it's actually, yeah. It actually kind of waters down the message quite a bit. All right. Our CVAs are essentially broken down into two types. They are either ischemic or hemorrhagic. If you see 10 people today that are all having strokes, 7.5 of them are going to be experiencing an ischemic stroke, where only 13 or so, 15 or so, are having a hemorrhagic stroke. That means that most strokes you see are going to be due to blockages, not ruptures. I use this picture. It's pretty clearly AI generated, but I think it still communicates the right message. I don't know what this artery is running up your brainstem, and I'm not sure why that artery is escaping your brain, but in any case, the point is that ischemic strokes are because there's a blockage or a clot inside, whereas hemorrhagic is the bleed. It's a rupture of the vessel. What up?
You said like 87%? Is that of the cases of...
Yeah, I said I think 70, but 80. Yeah, it just means that like if we see 100 people that have strokes in our career, 87 of them are going to be ischemic. That more often than not, people have emboluses and thrombus obstruction instead of ruptures. Ruptures is a pretty severe thing, and it's not great. I struggled putting this chart on here. Not technically, it's actually very easy to copy and paste, but conceptually, I thought, I'm not sure if this gives the right message. I'm always a little concerned when we start delineating or differentiating like pathology and presentation. I would rather you be catastrophic. I would rather you say, oh, I just treat them all like they're hemorrhagic strokes. And I'm like, great, good, do that. But I suppose it's worth noting that if a person develops a thrombus or a embolus block, usually the harm is kind of done. And they're not going to get worse unless they died. So they just kind of like develop facial droop because it's just killing that part of the brain. And then they just kind of stay that way and probably, and oftentimes forever if it's an infarct. But if it's a hemorrhage, you are losing blood over time. You get way, way worse. And also, not only are you losing blood, but you're increasing intracranial pressure. So if you said, hey, describe to me a patient that is having a hemorrhagic stroke, I'd say somebody that has stroke-like symptoms and is tanking, is plummeting. You said, describe to me somebody that's having an ischemic stroke. I'd say, well, it's probably somebody that's got some deficits but largely plateaus out. And you say, oh, okay, so I'll just remember that because they can neither one of those things can be untrue. I'm like, no, it can be either. I mean, you can have all kinds of issues. I mean, imagine a guy has a stroke, an ischemic stroke, in an area that controls vital signs function, and it starts disrupting other, you can die from that, you know? It's less likely and you usually stabilize out, but...
Because hemorrhagic, is the blood loss relative for the brain, or is it pretty...
Yeah, you're not dying from hypovolemia.
Okay.
If you are dying because the blood is squashing your brain and ceasing your functions. It's a good question. I also don't like this chart because it almost makes it look like you're getting better with hemorrhagic because it's going up.
Yeah.
Anyway.
And it's in blue.
And it's blue. Yeah. Oh dear. Now, an ischemic stroke, like I said, put simply, it's caused by a blocked cerebral artery. I had to go back through the slideshow and add cerebral everywhere. It's just like saying coronary artery disease versus atherosclerosis. Like atherosclerosis can be anywhere, in your brain, in your legs, whatever, whereas coronary artery disease is specifically a coronary artery. This stroke stuff is all cerebral arteries. The risks is atherosclerosis, right? Atherosclerosis, of course, is the plaque buildup. Well, if you get plaque buildup in your heart, it can lead to a heart attack. If you get plaque buildup in your brain, it can lead to a brain attack, right? Does anybody remember that isn't Landon why atrial fibrillation leads to stroke? That is a good guess to say that because your heart is beating so fast, you're not moving enough blood. If in isolation, if your heart beat so fast you couldn't move blood, yes, you could have a hypoxic brain event or a stroke, but that's not the problem with AFib.
It's because
First of all, I love these answers. It has no, but you're cluing into perfusion and the equation being volume and rate. These are great answers, just wrong, but they're great answers. Aiden?
Is it like stagnant blood, like coagulates? And make clots?
That's it. Now, and I should amend. If you have AFib that is so fast that you're not moving blood, like we'd call it RVR, rapid ventricular, yeah, you could be true. If it was so fast it wasn't getting enough preload and therefore, so you could be right, but this is what I'm trying to get at, that if your atria are not contracting appropriately, then they're not overfilling the ventricles like they should, and residual blood is staying in the atria, and it turns your heart into a clot-making machine. You can live your whole life with AFib. That's not generally what kills you. What kills you is the fact that it's making clots. Most people with AFib, I think something like 60% of AFib patients or sorry, 70-something% of AFib patients are over the age of 60. It's just essentially like degradation of the heart. So this is where I say the regularity of the heart is important. If I show up and a guy is unresponsive and I check his pulse and it's irregular, I'm starting to wonder, maybe it's AFib, maybe it made a clot, and then it either caused a stroke or a heart attack. Even though he's unresponsive, I'm immediately thinking that. It also makes me want to think that if I palpate somebody's pulse and it's irregular, what medication am I suddenly very curious about them taking? Aspirin, NSAID maybe, but more to the point, if you have an irregular heart rate, I'm immediately going to ask, do you take any blood thinners? Why am I asking that?
People with AFib take blood thinners.
AFib take blood thinners because if you have AFib, then you chronically make clots, which means they very often prescribe blood thinners. So, which patient are you more concerned about falling down a flight of stairs? A patient with a chronically irregular heart rate or a person with a normal heart rate? Because chronically irregular could imply AFib. If you're on AFib, then you're probably on a thinner, which is suddenly going to make that flight down the stairs a very different world, right? Yeah, okay. Now, there are a million different stroke scales. I don't super care which one you use. I know which one you're going to use because it's the same reason I use it, which is essentially the Cincinnati stroke scale, but what the hospital has taken and calling FAST, because FAST stroke scale is the Cincinnati stroke scale with time. We'll get into what that looks like.
Do you want us to just know these two?
You need to have one. You have to be able to appropriately assess a patient for a stroke. If you said, well, I downloaded an app that uses the Los Angeles Motor Scale and it's got 37 questions to it, I'm like, okay, as long as you don't delay transport, I don't care which one you use. I recommend you use the FAST because it's 3 easy questions. Here's the Cincinnati stroke scale is essentially just the first 3 parts of this, but time is super duper important, and we're going to get into why. So how this would go is if I walked in and saw perhaps Landon with like facial droop, I would want to do a stroke assessment. For my student brains, if you're like, okay, well, where does this fit in? I would say this is essentially fitting in during your focused assessment. I don't care if you interrupt your ABCs to do this. You walk in and I say, hey, Landon, how you feeling? And he says, yeah, good, fine, whatever. He's fine. And I'm like, oh, okay, but I notice facial droop, and before ABCs, I'm like, oh, I'm going to do a quick assessment here, but it goes quick,
Yeah, like that.
I don't mind you interrupting ABCs for that. But if it takes you 13 minutes to get through that stroke assessment, and then you're like, what's his airway like? And I'm like, oh, Strider. Okay, you're having a problem. So where it neatly fits is go through ABCs, then do that as part of your physical assessment. And all it is something like this. Give me like a slurred speech response. Hey, brother, my name is Mr. Fearon. I'm here with Chat Tech. How you feeling?
I'm feeling
Well, is that normal for you? No. You have any alcohol you want to share? Okay, then I'm very concerned you might be having a stroke here, brother. Here's what I want you to do. But I immediately identified a sign. I ruled out some obvious nature stuff, right? And I just go into the assessment. And this is what it looks like simply. First, we check facial droop. Check, right? I could see it, right? Now, if I need to check it, this is the phrase I use. Give me a smile so I can see your gums or teeth. Now, part of that's just a Mr. Fearon-ism because sometimes people don't have teeth and it can be a little awkward when I'm like, give me a smile so I can see your teeth, and it's just a mouthful of little black dangly bits or whatever. So personally, I just say, hey, give me a smile so I can see your gums or teeth, So they give me a smile, and I'm looking for symmetry. I'm looking to see if they're smiling in the same way. Because if they aren't, then it means that part of their brain might be having hypoxia and a motor sensory issue, right? Or a motor sensor part.
How does Bell's palsy tie into that? Like, is that a sign of Bell's palsy? Like, how does that tie?
That's a good question. The question is, what's the association here of Bell's palsy? To put it very simple, facial droop that's a stroke is because your brain is dying. Bell's palsy is an issue with the nerve in that face. Now, the stroke in your brain disrupts the nerve, no doubt, but if it's just the nerve, I ain't worried about your brain. And if you,
Like, would you know though?
only if they got a history of it, and even then, I don't super care. So if I showed up, for example, and you said, hey, my sister is not feeling good, and I was like, hi, and she's just like, hi, and just had this half face melting looking thing, I would say, whoa, is that normal for her? And she said, yeah, she's got Bell's palsy. I'd say, okay, I am still not ruling out a stroke in any way here. I have to go through the other stroke assessment. If that's clear as a bell, I'm like, are you on thinners and da-da-da? And if Kendall's adamant and saying, no, my sister always looks this way, I'm gonna say, okay, but today she's complaining of weakness. Her blood pressure's okay, her heart rate is okay, her lung sounds are clear, she has facial droop and weakness. That could be a stroke. And if she's like, well, but it's not. And I'm like, okay, well, let's play a game where we both don't know, and we take her to a stroke. I'm not saying she should or shouldn't go. I'm saying she should go. Is we go to a stroke center, because if you're wrong, then she develops a new deficit. If I'm wrong, we just went 10 minutes in the wrong direction, whatever. So anyway, Bell's palsy is a very common stroke mimic, and it just kind of involves, I mean, if she get called for chest pain, I'm probably not worried at all about the facial droop, especially only if somebody on scene says it's normal. But even still, I'm telling the doctors about it. We're en route to your facility with a, what is she, 37-year-old female probably, complaining of chest pain. Please note the patient has left-sided facial droop. Family on scene say it's normal. But there's no universe, I am not mentioning it, because it could be a stroke.
Thank you.
So we go through facial droop here. Give me a smile so I can see your gums or teeth. And then I'm looking for arm weakness. But again, I'm still looking for unilateral deficit. Part of that is the word ipsilateral means same side, right? Like if my tongue is over here and my thumb is up over here, we're on the ipsilateral side, it's the same side. Very often, essentially, your brain is controlling the opposite side. So if she had right-handed problems, my suspicion is that there's a left hemisphere brain issue, right? Largely, it's uncommon to consider that we are somehow suddenly having a stroke on both sides. So bilateral arm weakness would be a weird thing to have if it were a stroke. Because what are the odds that here you are, right as rain, and then suddenly this vessel over here and this vessel over here burst at the same time? Like what? No. Or a clot is rolling from your leg up through your heart, somehow bypasses your lungs, and then breaks into two and goes to both hemispheres of, no. We're looking for unilateral deficits in most cases.
So the side that's drooping, do you expect that side to drop or stay up?
Well, I would expect that if they have a issue on one side, that it's the whole side of that body, but it may not be, because again, it depends what part of the brain is impacted. If it's a tiny little clot and only in the part that controls the innervation of your arm, then that's only going to be the arm. If it's in a big old part that controls like your lungs and all these, dude, you're going to have massive deficits, right?
Is it also a matter of time? Like
Time is very
does it
important.
get worse, or does it affect the whole body over a period?
It can get worse. I will say this, hemorrhagic usually get worse before they get better, whereas your body can sometimes break clots up with its natural processes, and we'll talk about TIAs later. But anyway, so if I had Kendall here and I said, hey, I think that you might be having a stroke, maybe all she's complaining about is a really bad headache today. I'd say, okay, well, give me a smile so I can see your gums or teeth, right? And in her case, right, we're really glad we asked about the gums. And now I say, well, I want to test the arm drift. So hold your hands out like stop in traffic. Very good. Now close your eyes, and I just want you to keep your arms there for 10 seconds. Now, I never wait 10 seconds. That's what they say. There's no drifting here. But if I saw this like drifting down, I'd say, hey, no, keep your arms straight. This is one of those situations, you can relax right now, but one of those situations where I always am like, you're going to get a patient with like a broke thumb, and you're going to go in there like a little, just so gingerly, like, does that hurt when I do this? Does it hurt when I do that? And then you're going to see a radiologist, and they're going to be like, all right. And they're just going to, you're going to be like, oh my God. And it's like, yeah, you have to be kind of harsh with these things. This is one of those instances, I come in sweet like Sunday morning, but you have to be very direct in stroke assessments. And so I say, hey, hands up like you're trying to stop traffic. Very good, just like that. And I see this arm drop. I'm direct. I'm like, no. Both hands directly together. It drops again. I'm like, okay, can you not keep this arm up? You have to be direct, because if you are, I don't want to say guilty, but if you are convicted, I can't get away from the legal, if you are positive for, if you're presenting with one of these signs, facial droop, arm weakness, or speech deficit, you are in the neighborhood of 76% likely to be having a stroke for one of them. You are upwards of 90% if it's all of them. So this is why you have to be direct, right? So I'll be talking to somebody and they'll be like, yeah, I can't, blah, blah. And they're slurring their speech. And I'm like, hey, look at me. Don't slur your speech. Say your name clearly. Say it clearly. Say your name. Kendall. Okay. Because sometimes people are sick, they don't feel good, and they're just not putting the effort into it. Because I'll tell them straight up, I say, hey, look, because of this deficit, I'm going to run lights and sirens. We're going to call a surgeon out of bed, and he's going to come take a look at your brain, because that means stroke, what you're doing there, which I'm fine with. I love taking care of people. But if you can stop doing that, then you should, right? Because it's the matter of being very likely in the camp for a stroke or not, right? So you'll look at something like facial droop here can be pretty obvious sometimes, but it can also be incredibly subtle. I will never forget going to the Marietta Square where a woman had called for a man she thought was having a stroke. I walk up, I looked at the dude, and I was like, who called? How do you feel? He said, fine. The girl next to me, she said, I called. He's got facial droop. And I'm looking at him, and I'm like, maybe? I mean, maybe. I said, are you like his daughter? She said, no, we go to church together. And I was like, are you close? And she's like, no, I see him every Sunday for the last year or two. And I'm like, man, are you a nurse? And she's like, no, I'm in banking or something. And I'm like, man, I would have never noticed this subtle, and she noticed it. And I was just, but the whole time I'm thinking, he's asymptomatic other than that, And I'm like, what's the big deal? Dude, he was having a stroke. She saw it a mile away somehow. And I'm like, I'd seen people die of strokes before, and I'm like, I guess so. Okay. He was having a stroke. It was just this very subtle cue. So sometimes it can be very dramatic, but also sometimes it's incredibly subtle. Again, I'll teach you the facial droop, speech deficit, and arm drift, but what I'm telling you is consider that everything you can feel and do comes from your brain. So therefore, any presentation could be a brain problem, right? So we'll use the fast scale because the time part matters a lot. We'll get into that later. But also, again, just if someone called 911, something changed today. It could just be subtle. We'll talk about some of the other subtleties that incorporate in. One of the things I thought was interesting is that I did all these facial droop things, and I found a bunch of white people. What's interesting here is that you are 50% more likely to have a stroke if you're black. By some metrics, I saw a record saying that 50% more likely to contract a stroke if you're black, and somewhere 10% more likely to die on some articles I saw. I think the answer for this probably falls pretty neatly on socioeconomical stuff, not anatomical. Like if traditionally black Americans have lower income, they have less access to health care and good food. And so I have a strong suspicion that that's why, that it has nothing to do with their anatomy, that it has to do with their class or whatnot, economic status. But in any case, we need to be therefore far more suspicious of subtle clues if you're black, or if the patient is black. If you're black, you don't have to be anywhere near as concerned. So this fast scale is the Cincinnati stroke scale plus time. And the reason why the time matters is hopefully dependent on my next slide. It isn't, so we're going to just talk about something else. This, for example, is the Los Angeles pre-hospital stroke scale. Has it become readily apparent why I've chosen the Cincinnati stroke scale? Now this one's good, but again, the Cincinnati stroke scale is not bad. If you're positive for one of the signs, you're about 3/4 of the way to being sure this guy's having a stroke, right? So use whichever one you want. I recommend use the easy one. There are other several questions. If you got to use the bathroom, I recommend that you use a diaper or you just head out because we got about 40 minutes and go real fast here. So surprising no one. Additional questions you need to ask about stroke is their last known normal. This is absolutely integral, absolutely important for your stroke assessment. Anything. Whatever your situation is today, when was the time where you were not this way, right? So if it's facial droop, when did you notice the facial droop? Well, I just felt a little dizzy, so I got up to brush my teeth or whatever, which is definitely what you do when you're dizzy, and then you noticed that you had facial droop in the mirror. Or I was laying on the bed and I suddenly got a headache. Or it was about an hour and a half ago when my wife went to hand me a glass of milk and my arm, I just dropped it, right? So that time frame is important. Another super important question is whether or not they're taking any blood thinners. Now, some patients don't know what those are. So if you suspect a stroke, make sure that you're taking all of their medications or at least listing them. Because if they're on blood thinners, it could also dramatically affect where you go and the treatment they receive, and we'll talk about that in a second. Landon?
Do strokes affect a certain demographic? Can happen at any age?
I'm sure that, like everything else, the threshold is 40 and 65. That a guy with chest pain at 39, we're like, who knows? And when he turns 40, you're like, heart attack. And then when he gets 65, you're like, definitely a heart attack, you know? So my guess is that, but I don't know.
Okay.
My guess is that, I don't know. Now, to fix these occlusive strokes, a lot of times what they can do is administer medicine called TPA. I think I might have wrote down what that stands for, something altepaste. I don't remember, but TPA is, yeah. TPA is a clot-busting medication that the hospital gives. The reason I bring that up is because if your last known normal is greater than 4.5 hours, they won't give it to you. If you're on a blood thinner, they won't give it to you. Because hemorrhagic strokes are far more lethal than occlusive strokes. And the longer that stroke has been occurring, the more likely you are to bleed to death, in a sense. If you're already on blood thinners, the more likely you are that TPA is going to cause you to have a brain bleed. So again, part of the reason why we ask last known normal, and if they're on blood thinners, is because we're really trying to determine, are you even a candidate for TPA? Roman?
This is for like paramedicine.
It's for doctors.
Okay.
Doctors
So
give
so
TPA.
Paramedics can't use it.
So far as I know, it is only administered in the hospital through an 18 gauge in the right AC. Antecubital space. So paramedics aren't, there are, Grady has stroke trucks. They've got, what is it, CTs on them? They can scan your brain in it. So I want to say no, paramedics don't do it, but in my brain I'm like, there might be a medic giving TPA on a truck unless it's a doctor. I don't know. But
I know a nurse medic personally that works on that exact truck that does.
gives TPA?
I'm pretty sure.
Yeah, see, that's what I mean. So to answer your question specifically, my experience is usually doctors are giving it in the hospital, but it's possible that nurse medics are giving it in very specific situations in the field.
I mean, nurses physically give it, but doctors order it.
Sure, fair enough. Yeah, I suppose that distinction wasn't so necessary. Okay, so I walk up, I see Aiden, I go through this stroke assessment, arm drift, facial droop, slurred speech, and I see one of those things. I'm like, okay, I have a series of questions now. Like, when did you notice this thing? Are you on any blood thinners? And what is your sugar? Why do I care about the sugar?
Because in a stroke, it was like increased glucose or something like in the.
Not quite, not quite. Go ahead. Yes, they can look exactly the same. But think about it, you know this already, right? Bailey gets a clot in a cerebral artery, so what's not getting to that part of her brain? Oxygen, and so if a person is hypoglycemic, that's half of the metabolism equation, it can look like a stroke because this part of your brain isn't getting sugar and it's now causing facial droop. So make sure you check it. Here's what you don't want to happen. For a guy to be sitting there with facial droop and you'd be like, blammo, you got Bell's palsy? And he's like, no. And you're like, stroke, I'm a genius. Let's drive 20 minutes east to the stroke center, and 10 minutes down the road, you check his sugar and it's low. And you give oral glucose and his facial droop goes away. And you are now like, whoops, let's go 30 minutes in the other direction to where he wanted to go in the first place or whatever, right? So make sure you're checking sugar because it definitely can mimic strokes.
So what's the last known normal for the requirement? Is it less than that? Or?
So I used to just teach flat 4.5. It depends on the location and protocol and all this different stuff. Many hospitals say they won't give TPA if your last known normal was greater than 3 hours, but many of them will also say, no, we go to 4.5 in more advanced situations. So I would say as long as you're asking them the time frame, if he says 1 hour, 2 hours, 3 hours, or 6 hours, you report whatever that time is to the hospital, they'll deal with it.
Yeah, so we don't have to like determine, oh, you're gonna get TPA when you get there. Just tell the hospital and they decide.
Yes, but it might determine if I said 10 minutes east is a primary center and 10 minutes west is a comprehensive center, one of those has surgery, the other doesn't. If you have a wake-up CVA, like I show up and I say, hey, what happened today? And you're like, oh man, I looked at the mirror, I'm like, what the hell is this? I'm like, when did that happen? And you're like, I don't know, I just woke up with that. I'm like, well, when did you go to bed? And he was like, 9 last night. I'm like, okay, then your last known normal is 9 o'clock last night. We are now 12 hours past the window. Whether it happened 10 minutes ago or not, if you say, oh, I'm just gonna go to the primary stroke center, right? Like go to primary school first, then we go to advanced school or whatever, right? I just go to this local hospital, they know me. And I'm like, brother, they're not gonna do anything for you. You were way outside of the window for TPN at 12 hours. That's greater than 3 or 4.5. We have to go to the comprehensive center now. Cerebral vascular accident. It's what you would do if you're trying to press a chick at the bar, and then afterwards she'd be like, do you mean stroke? And you'd say, well, yes, but I'm so lonely, so lonely. So we talked about thrombectomy, which is the surgery. This should look somewhat like our heart attacks, right? And the fixing of at a PCI center. You can see the wire goes in, the mesh balloons, and then it pulls the clot out of your brain.
Vacuum, basically.
There is a vacuum, but mostly I think it's just dragging it physically. Now it will literally pull the clot out. So if you've got a clot here and the TPA either doesn't work or can't be administered because you fall outside of the range or window for it, then you need surgery or else that part of your brain stays dead. So here's the interesting thing. And I also think that I read somewhere that TPA is only effective like 30 or so % of the time. Here's a weird message. It's one of the only moral conundrums I think I experience in EMS. If I've got a patient who said that they think that around 3 hours they started developing these symptoms, but they're not sure, I would say, okay, well, the local hospital says that it's 4-hour window, you fall inside of that. We should go to a primary center. Because if I took all strokes to comprehensive centers, they'd be overwhelmed. So if you qualify for TPA, you should advise that patient to go to that place that does not have surgery.
What the
Primary. Mm-hmm. Now, if I'm talking to Aiden, and Aiden's like, dude, I want to go to comprehensive. I was in your EMT class. I know that if the TPA doesn't work, I'm going to need surgery. I'd rather not have to drive to the other one. I'd say, absolutely, sir. I'm happy to go where you want to go. But we can't overwhelm them. There's not many of them in the state. And what we don't want is for all 3 of you to be in the same bus and to be having a clot that can be attacked by TPA, but I took you all to the comprehensive stroke center that can do surgery, and Almeda needs it, but can't because she's in line behind 3 people that should have gotten TPA at a different place. You see what I'm saying? Okay. But if it's my mom, we're going to comprehensive stroke center. Why? Because they have surgery. It's a one-stop shop.
And if they need it, then it's right next door.
That's correct. It's about one of the only moral conundrums I've experienced. I do think you should be advising people that can be TPA candidates go to primary stroke centers.
But what if they need surgery?
Then they'd have to be transported out.
But that takes time too.
It does. But what I feel more responsible for is not if I show you here's a map, right? Here's a map. In green are our comprehensive centers. In white are our primary centers, right? I don't know how many they can handle at one time, but it's not many. And if we're in this mindset where we just take everyone to comprehensive care because that's what we do, and we never think about TPA windows, then they're going to get overwhelmed. And so that's why
It takes longer to drive to a comprehensive, so that's
it depends. But yeah. So put very simply, the primary center has TPA, comprehensive has TPA and surgery. There's a bunch of other qualifications here. I think there's like 4 different types of centers, but I only care that you know the 2. Yep.
maybe that
Thrombectomy. Make sure you know these terms. I know you're going to get frustrated when I skip by this, but you just have to look at the slides. Here's the highlights. Aphasia means that you can't speak or understand speech. Dysarthria is slurred speech. You will never hear that word in the field. You will just hear aphasia for all kinds of verbal issues. Sometimes you can be so correct as to be misleading. Like if you were like, if you call in and say, I'm responding lights and sirens to the hospital, I've got a 47-year-old male complaining of dysarthria, that nurse is going to say, what is that? Aphasia, however, is what they're going to expect. But actually, I recommend you say slurred speech, but yeah. But you're going to hear, fire's going to say, hey, we got a guy with aphasia over there. And he's like, what's up, man? And you'll be like, okay. No worries. Stroke is what he meant, and I'm okay with that. Yeah, I love strokes. All right. So make sure that you know these things. But again, these are just different areas of your brain that are being affected, being represented this way. The big ones you need to know are aphasia, all of these. The big ones you need to know are on this page. I already isolated them from all the other ones in the book I don't think you super need to know. Dude, so many. Aphasia is the most important. Ataxic is muscular. I suppose if you had to only know 2, I'd pick those, but I think you can aim higher. Here's why agnosia is important, okay? Agnosia. It's Latin for, I'm breaking up. I don't remember what it's Latin for. Knowledge, probably. Here's what Mr. Fearon adds to his FAST assessment, right? I'll do it with Haley. Hey, I just want you to give me a smile so I can see your gums or teeth, or at least as many as you have. Go ahead and hold your arms out like you're trying to stop traffic. Good, keep them just like that, but close your eyes. I don't want them to drift at all. Very good, go ahead and relax. And now say you can't teach an old dog new tricks. Okay, now generally speaking, honestly, as a clinician, I rarely ask the speech one. By then, I'm usually talking to somebody enough that I don't need to. It never ceases to amaze me. It's like 17 minutes into a scenario, somebody will be like, cat jumped over the moon or whatever. And I'm like, have you not discerned by now? But whatever. Okay, so we've done the 3 parts of the FAST thing, and then I say, hey, you were with her. When was the last time she was normal? Assuming she's ever been, right? When did she not have this deficit? Oh, it was an hour and a half ago? Great, now we can go to a primary stroke center. Do you take any blood thinners? No? Fantastic. What's your sugar? 97? Awesome, we're going to a primary stroke center because it's close and because I think you might be having a stroke. But here are the things I add because I want to test agnosia. Okay, sweetie, looks good. What is this? What do I use it for? To tell time. What are these? And what do I use them for? To see. Good. I have caught strokes before where they had no symptoms at all other than just communication with them was odd. It would be something like this, like if Mr. Harris is just starting assessment with me like a clinician, I'm the patient. Say hi and...
Hi, how are you doing? I see your face.
Hey!
Medical.
Yeah, how are you?
I'm fine.
Okay.
Why'd you call us out here?
Sorry, what's that?
Well, somebody called 911 for us to help them.
It was probably my wife. She gets really like overreacting sometimes. Like there's a hiccup there. There's a hiccup there in that communication, right? I have caught several strokes before because I was just like, something's off. I go through a stroke scale, nothing. I go through sugar check, nothing. And then I'm like, what's this? And they're like, it's a I'm testing their visual ability and their visual memory. It's a different part of the brain not checked by these. Sometimes I've had them write before. They're like, yeah, it's a watch. Yeah, it's glasses. I'm like, okay, just write your name down for me. And they're like, STE trails off the page. And I'm like, okay, that's a stroke. Or something's happening to their brain. So,
Oh, actually, so like the vocabulary is like what part of the brain is affected. That's why you do all this to figure it out. Like,
yes, ma'am.
Like figure out like which part is affected.
I think that you can cover most of the ground with these three things. And if it's all you remember, that's great. But if you can add on to it, like, what's this and what's it for, you're going to catch another portion. If you ask the LAHSSPM key TT scale or whatever, you're going to probably catch more because there's more questions or whatever. So that's why I always say, hey, you can layer some of these things in for sure. But the most important thing is do the fast scale and trust the hairs on your neck. If something seems off, poke their brains in different places. Hey, do you remember the lines of your favorite song? Say that for me. Where did you grow up? Draw your name. Draw a circle. Draw a square. I'm going to say a shape. You say it back to me. Pink triangle. Now you say it. You know what I mean? Like you can dig a little deeper. Sorry to delay.
No, onto that note though, that's why now this won't ask weird questions like puff out your cheeks. Like,
Yeah.
Because they're testing cranial nerves. You know, they're wanting to whittle it down.
That's what they're really doing, is they're checking all of the innervation of your brain.
But to what I was going to say earlier, I think it was you and I that we just brought in like some
Where the chick laughed at us? Were you there for that?
maybe. But we were holding the wall for like 45 minutes at Kennestone, and we witnessed the stroke happen right before us just because we had been conversing with him the whole time instead of just kind of like ignoring our patient while we hold the wall.
Right.
We were like, just passing time and socializing and being polite and stuff like that. And then suddenly he's like, we're like,
Yeah.
say that again?
So the patient just started slurring all of a sudden. And since we were the only ones drinking, that was super weird. Yeah. I am recording my lecture. That's why I'm kind of repeating what you're saying back, but so it picks it up. But yeah, no, I think that's wonderful. Absolutely. To put the finest point on it, I called in a stroke. I said, hey, my patient's negative for fast symptoms, but he's experiencing what they call autonomic aphasia, right? I'm calling in a stroke alert. We're going to see you instead of, I show up, neurologist, doctor. And they're like, hi, sir, put your hands out. They do the whole thing, right? And then they're like, what was the symptoms? I said, he's got autonomic aphasia. Like, he doesn't know objects. And they're like, they looked at each other and they laughed. And they were like, okay. And I was like, okay? I mean, I didn't go to school 14 years and tear apart someone's brain. What do I know? I just read a book, you know? So then we're walking down the hallway, and the neurologist wearing very high black boots, do you remember? Okay. Clickety-clack or whatever, looking ripe as a peach. She's like, hey, tell me about his his slurred speech again. I said, he doesn't have slurred speech. He can't recognize objects. And she's like, really? And she pulls out her pen and she says, hey, sir, what's this? And he goes, and his face melts. And she was like, this is a stroke.
I bet you're like, no shit.
I was like, well, I mean, I don't know. All I had was a certificate at the time, but you told me what it should be.
Interesting.
What's the line in Good Will Hunting? You'd be amazed what you could get for a fine in a library or something. Like, I guess you could go to school for 2 decades, or you could just believe it when it says, I don't know. Anyway, I kind of hate those stories. Everybody's story is like, there I was, a room full of ignorant people, and I solved the problem as the smartest man alive. But in this case, it was true. Okay. Well, and then she saved his life. I mean, I was like, it's a stroke. And she's like, do you want to say it again? Is that going to help? And I'm like, well, no. Can you please do the surgery?
It was hilarious how the sense of urgency went way up.
Dude, it irritates me to this day. Especially since, like, I'm not a nunce. That wasn't the first time I've met her. We've had a million conversations in the last...
We also used this moment as a teaching point because I think we had a third rider that we already had like a few blood sugars. We did a 12 lead. We had multiple.
Dude, I'm going everywhere.
So now that it's suddenly like it's legitimate, we have the backlog of all the stuff that they would have
Isn't.
wanted if
Yeah.
they were,
Yeah.
like,
Oh, yeah, I misunderstood your point. Yeah. They're like, wait, we all of a sudden, 30 minutes deep, think this is a stroke. We should get on all this stuff. And you're like, okay, we've done all that. Yeah. So your body can bust clots. We need to talk about a transient ischemic attack. These are traditionally, well, only when you have a clot, so an ischemic stroke, but then your body wins the fight against it. You have a clot, you get facial droop, arm tingling, numbness, slurred speech, whatever it is. You load up the patient in the on the way to the hospital, you're going through your assessment and it's gone. They're fine. What happened? Well, their body broke the clot up. And we call that a transient ischemic attack. And it's pretty common. The book says, signs and symptoms dissolve within the first 24 hours, and that's going to be the test question. How would you know? Well, it resolves within the first 24 hours. That's the TIA, right? This usually happens in the first hour. A clot happens, your body breaks it up, and it's fine. It sucks for us because we get a person with like a full-blown looking stroke, and we're like, boom, boom, let's go to the hospital. And by the time we get there, they're like, he's fine. And I'm like, he wasn't, though.
Can they see that on the MRI?
No, not if it's just ischemia, because it will largely have healed by then or whatever. So, huh? Think about it like how I've got a thorn in my finger. I pull the thorn out. Once the pain fades, there's nothing there anymore. I guess unless you count that gaping hole. But the point is that it is very. Gentlemen, have you run TIAs before?
Yeah.
Dude, it sucks.
I swear.
Yeah. You show up, they have some pretty profound symptom, and by the time you get out of the driveway or pull up on the ramp at the hospital, they're fine. And you're like, I swear. There's so many times I wanted to take a picture. Roman, I think.
So what's their problem then if they're having if it's transient? Why is it disappearing and because it could happen again?
Yeah, the question is what is the problem? The problem is you probably have atherosclerosis. You probably developed a thrombus or an embolus that is now embolized or clotted somewhere, but your body can handle that. It goes over, it sends all these hormones I'm going to pretend like I know the names of, but you're just not smart enough to remember. It's going to send all these things I don't want to talk about, and it's going to break that clot up. Obviously, I don't know what those hormones are called. So this is experiencing a solution. They had an occlusion, their body broke up the clot, and now they're fine. However, whatever started that in the first place hasn't gotten better. They probably still have atherosclerosis, they probably still have a thrombus somewhere, and they probably still have emboli running around all over the place.
What does the stroke center do for them? Nothing?
Well, they would probably clear out their vessels. This is what's so important. You will hear TIAs. I say, sir, have you ever had a stroke before? They say, well, I had a mini stroke, and I hate that. That's why I gave it a thumbs down emoji, because it makes it feel like NBD, little mini stroke, just call me on the street, little stroke, right? Like, those who have a TIA, little stroke, those who have a TIA, 1 in 3 of them will have a full-on cerebral vascular accident, and often within the next day or the next few days. Mini strokes are a sign that your body is making and dealing with clots. Something's very wrong.
So they keep them at the hospital for the 3 days to see if...
Probably, I don't actually know. But it wouldn't be unwise. It depends. They can do a scan of their head and if they're like, you're clear as a bell, then they're probably sending them home. But if they pull it up and they see a bunch of partially occluded arteries, probably not. Yep.
That kind of reminded me of the stable angina stuff.
Yes.
Can people have vasoconstriction in?
If you're asking me if people have chronic vasoconstriction issues of cerebral arteries, yeah. I don't know that, but it wouldn't surprise me. I'm definitely not teaching it to you. Now, so we had ischemic strokes, which are largely just obstructions. Now, whether or not that's a thrombus, which of course is a bleed and a coagulation in the area, or an embolus, which is a broken off piece of that thrombus, or a clot, or air even could be an embolus, right? A hemorrhagic stroke is literally the rupture of the artery. Now, I want to make the distinction here. It's not an aneurysm. Aneurysm is a balloon. If that aneurysm somehow got a clot in it, that would be an obstruction. If that aneurysm ruptured, it would be a hemorrhagic stroke. But the aneurysm is just the ballooning. Okay? Don't worry too much about subarachnoid distinctions. I thought we might have a little more time, and I was going to kind of talk about what that means. You can largely ignore that language. Just know that if a heart attack is an issue with your coronary arteries, a hemorrhagic stroke is a rupture of your cerebral artery trying to fuel your brain. Hopefully no one is surprised to find out that not hypertension. If Mr. Harris, I checked his blood pressure and it was 190 over 110, I'd be like, that's not good. And he's like, should I rush to the hospital right now? I'd say, no. Go to your regular doctor in 3 days. They're going to figure out why your blood pressure is high. But if you live every day with high pressure, it's going to force pressure on all of your arteries, and it's going to cause aneurysms. It's going to cause thinning of your arterial walls if you live with chronic hypertension. So if we know you have an aneurysm, and sometimes people, maybe a guy had a seizure, he passed out, they take a scan of his brain, and they're like, whoa, you got an aneurysm in there, buddy. Now for the rest of your life, once a month, we're going to take a picture of it and see how it's doing. Give me a call if you've got any weird symptoms. But hemorrhagic is the bleed. Now, I'm going to skip through a bunch of this and get to a point here that I want to make, which is just to say that I think intellectually we need to understand what we should suspect. Like if I said, you have a patient who is experiencing a stroke, is it ischemic or hemorrhagic? What should you suspect? Why? Oh, that's fun. I know where you're going.
I know where you're going too.
Yeah.
Hemorrhagic is worse, so you treat everyone as if they're hemorrhagic.
Let's say both
You would
answers.
give them aspirin.
Oof, no doubt about it. I guess what I'm trying to say is I like both of these answers. I'm going to suspect ischemic because 85% of the time they're ischemic. Okay, that is what you should suspect. I'm okay with the answer. I'm going to suspect hemorrhagic because I always suspect the worst. These are both great and honestly right answers, right? Now, what it is different than what you should suspect. What you should suspect is, based on the presentation, which one is more likely. That's the framing, right? So if I've got a person with AFib, I suspect ischemic obstructive shock. Why? Or not shock, but stroke. Well, because AFib makes clots. Clots don't make you have hemorrhagic strokes. Burst vessels do. You got a patient who is complaining of left-sided facial droop, has a history of AFib. What should you suspect? Because it's probably a clot issue, right? Because of the AFib. Could it be hemorrhagic? Yes. Should you suspect in clinical sense that it's hemorrhagic? Yes. Okay, but we've got other things. You know how I said Cincinnati Stroke Scale is the FAST, right? How I said you should add agnosia. Do you know these objects and what they're for? Worst headache of your life is a stroke symptom. Subarachnoid, which are essentially, one is bleeding inside, one is bleeding outside, but they are both cerebral arteries.
And are they both indicative of a stroke?
Yes. One, thunderclap, is subarachnoid.
Okay.
So, if I said, oh man, Kendall's language just a little off, but not Cincinnati stroke. She knows this is a watch. She knows these are glasses. She said, I just called because I got a headache. I said, how would you describe it? Not so bad or worst headache of your life? And she's like, honestly, worst headache of my life. I'm thinking hemorrhagic stroke, we go to the hospital for a stroke. I've even told people before, I said, hey, if you mean to say it's real bad, let's say 9. But if you think this is the worst headache of your life, then say it again. She's like, worst headache of my life, for sure, right? So hypoglycemia can mimic stroke. Migraines can mimic stroke. Why? Well, because migraines are very bad headaches, but we are going to err on the side of catastrophe, okay? Now, we give aspirin for chest pain suspected ACS. We know that. Why would you suppose that if 85% of my facial droop patients, let's say, are ischemic, why could it be deadly to give them aspirin?
Because they're bleeding already.
Because there's a 15% chance they're having a hemorrhagic stroke, not an occlusive one.
And if we give them aspirin, they bleed more.
Yeah, you're either going to save his life or definitely kill him. You need to know the Glasgow Coma Scale. Now, you don't have to do a ton of work here, but you should know these things if nothing else. That everyone gets 3 points for showing up. That this slightly, oddly damp rag, it gets a GCS of 3, not 0. That, Mr. Thompson has a 15 right now, presumably. That by being confused, you lose 1 point, so it can be a bit misleading. And if you can remember that the first 4 here are just AVPU, then you got about 20% of the thing down in the first place. Okay? But you got questions coming that say, your patient is following this. It's my favorite question of the year. Favorite question of the year. It describes 3 things, and all students think that it's 2 things. It says, your patient is opening and closing their eyes and responding with this verbal, what should you do? And everyone says, you only gave me 2. And I'm like, no, it's in there. It's my favorite question, but it's coming. Know the GCS. Okay, so we talked about aspirin, we talked about blood sugar. No one should be surprised that a brain bleed or brain hypoxia can lead to seizures. What do we do? Here's what I'm going to do. I'm going to continue my lecture probably through lunch. You don't have to stay. In 5 minutes, you can leave. I'm recording it, so it'll be on YouTube, but I'm going to give it anyways since we're in the flow. So whether or not you take your full hour lunch now or you just wait till I'm done talking, totally up to you. I would say either decide to eat and leave or don't, just so it's not a bunch of noise and stuff. So I'm going to keep rolling. Ain't going to bother me if everyone leaves at time. Again, I'm recording this, so I'll throw it up on the thing. Cool. We'll take a 5-minute break here. If you're going to leave for lunch, now's the time. Okay. Let's see. Stop recording. I think we're good to go. Hopefully I didn't pick myself up in the bathroom. So there we go. Okay, we got to talk seizures. Seizures are largely broken down into 2 different types. We have generalized and we have focal. What this means is not necessarily specific parts of your body versus the entire body. We're talking about the brain. A seizure is an electrical storm in the brain. It's like a computer erroring out and rebooting. A seizure is just a lightning storm running through your thinking parts, which is making your whole body go weird. If it's generalized, it's usually a large portion of your brain, if not the whole thing. And if it's focal, it's probably just a very specific part going haywire. Where you'll need to understand the differences is on their presentation more than anything. If it's a generalized seizure, you won't be conscious. We basically have 2 types. We have the one where you wiggle around a whole bunch, like this fella up here. And then we have one where you do no movement at all. So you could just be catatonic, just staring in a direction. And I'm like, not responsive in any way, but all the way awake, right?
So focal seizures you can be conscious for?
Put very simply, yeah, a focal seizure could be a very specific part of your brain. Let's say it was only in the part of your brain that controlled your finger, and so your seizure was just this, just a crooked finger. And you're like, you call, and I've had patients like that where they call and they're just like, I got some kind of like elbow issue. I don't know why my finger's doing that. And my response is, it might be a seizure. And they're like, no, because I'm not shaking. And I'm like, no, it could be just part of your brain sending a signal to crook your finger like this. Or what it's oftentimes is a facial effect. I got this twitch that just won't go away. I'm like, okay, well, God willing, it's a nerve issue, but it could be a brain issue. It's a specific part of your brain, and it is represented usually. We notice it because it is a very isolated and localized experience. You won't be conscious during generalized. You might be during focal. If you can tell me about your seizure, you probably weren't having one. And people will try. They'll be in the middle of shaking. They'll be like, this is it, I'm having a seizure right now. I'm seizing. And I'm like, you definitely aren't. And I'll say this guy does not look like he's having a seizure. That's not how they look. Once you start seeing them, you'll be like, oh, there's a difference between a person shaking their whole body, it's like organized movement, and somebody that is just having a complete ataxic experience where their brain is misfiring all over the place. That guy, in no universe is that a seizure, but I will still treat it like one because it might be a pseudo-seizure. Now, listen to me when I say pseudo-seizures are generalized seizures, but they are not fake seizures. Pseudo-seizures, you can have epileptic seizures, right? You could have a tumor in your brain that's goofing you up and now you're getting the tonic-clonic motion. You could have absent seizures, right? Because it's maybe the neurology in your brain. But if it's your psychology causing a seizure, it's a pseudo-seizure. Like maybe you have a history of schizophrenia, and schizophrenia is telling your brain 2 things. It's telling you that strawberries are running for president, and today it's making you have a seizure. It's not an epileptic seizure, it is a psychiatric seizure. So pseudo-seizures are still treated like seizures. They're often given Versed and sedatives to scale people down. But in the field, people use that word to mean this person's faking it. Now, my recommendation is that you treat all seizures, even if they're pseudo-seizures, like they're life-threatening emergencies, and you're kind and you're respectable.
How can you tell if it's a pseudo?
You can't, and that's my point largely.
Oh, okay.
You,
Just treat it like a focal or like a.
yeah, I mean, you can tell in some ways. Like if Aiden right now is like, I'm having a seizure, I'm like, probably not, because you just told me you're having one.
Right.
But I don't know, not technically. And so there are definitely ways. Well, I'll walk up, somebody will have a seizure, and then be in their postictal phase, so they're not responsive, and we'll talk about that in just a second and the ways we can kind of determine that. Sebastian?
You like your little sternum rub or something?
Essentially, that's where we're going. Pam, did you have some? Oh no, it's Lauren, I think. No, you're good.
Pseudo one, it's kind of just like,
It's not.
it's like they're thinking that they're having one, but they're not really, but you wouldn't know.
It's like they're thinking they're having one, but they're not. I'm okay with that language. And so you're like, oh, well, they should stop. And I'm like, I agree. Go tell every anxiety patient, every psychosis patient, dementia patient, just tell them to stop. So yes, it's not epileptic seizures, but no, they can't control it.
So
It's their psychology making them do it. It's like if you had a patient that was like, there's somebody underneath my van and they're going to kill me. And you were like, oh, well, there isn't. So just stop thinking that. It's like they can't stop thinking that. That's what psychosis is. So we can often experience pseudo seizures with psychotic episodes that are not true seizures, but they are pseudo seizures. So the only reason I highlighted it is because you're going to hear it to mean they're faking it and we shouldn't care. And that's not fair. Like most people don't act that way because they wanna. They can't fight their own brain. That's why they take all these brain meds. So pseudo seizures still have the inherent danger of every other seizure. Seizures in general are dangerous because people fall. That's the number one reason. If I'm standing here and all of a sudden I smell burnt toast, which could be a olfactory aura, or suddenly I just bright light, I'm like, God, it's bright in here, and then I go into a seizure experience, right? This is what an aura means. Well, if you're standing, you're going to fall, and that can hit your head and change your life. It can cause a break or a bleed. The second reason seizures are dangerous is because aspiration. Maybe I'm on the ground. The first thing I do is if he says, man, I just feel weird, man, I feel dizzy, he's got a history of seizures, I'm like, sit down, buddy, sit down, right? Or lay down, or whatever. But now I'm watching his airway, because if he throws up during that experience and breathes it in, he might get life-threatening pneumonia, he might choke. So seizures are largely dangerous, not because your brainstorm kills you, but because you fall or because you suck stuff down your air pipe, right? I have heard of instances, because if you think about it, what if the seizure gets in your brain in a way that it makes your diaphragm stop working and then you asphyxiate? Like, I've heard of that, but it's just rarely the case. Usually seizures kill you because you hit your head or because you choke.
Yeah, I'm so sorry.
So for clarification on pseudo seizures, just one more time.
Sure.
You're thinking that you're in the middle of a seizure. Does that actually manifest into your body movement as well?
Yes, but with time and expertise, it looks more like the guy shaking.
Okay.
Because it's like me saying, hey, mock a wheeze. And you'll immediately start making noises with your mouth. And I'm like, that's Strider, arguably, make a wheeze. And you're like, I can't. I'm like, you can't seize either. That's a global experience in many ways. But you can make it look like it. But it's also not effective to just tell someone to stop doing that,
Is it also because they're like anxious probably, because they think they're having a seizure, so does it make it worse?
Sure, can. You can get pseudo seizures for any myriad of reasons why anyone's psychology. But maybe this is the easiest way to do it. If I have epilepsy, if I have chronic seizure activity, I will be giving a daily medication to prevent that seizure. It will have no effect on pseudo seizures. Why? Because they're not seizures, they're pseudo, they're fake. But they're not faking it, is the point.
They're not like charlatans.
Yeah, exactly. They're not like, watch this, it's a hoot. It's like, brother, any person that fakes a seizure in front of a bunch of strangers has got something wrong with them. Like, treat them with, something's wrong. I don't think they needed a seizure med, they need a different med.
Yeah, even if it's like, even in the situation where it's on purpose.
That's
like
right.
It's disordered behavior.
Something is wrong. Yeah, I don't do that. I would never.
Yeah, if you don't have
something's
the
wrong.
machine.
Yeah. Weren't you raised in a pseudo-Catholic environment like I was? What the hell's wrong with you? Yeah.
I was just gonna ask about the aspiration, right? Because when people sneeze, they have like the foamy stuff, and I just
They could.
I remember you saying something about like foam and bubbles equals a
It
liquid.
just means there's air. No, it just means there's air in the liquid. Now, whether it got there because you did it with your mouth or in your lungs, that could be different. So just think pink frothy sputum is bubbly and probably means congestive heart failure. And if you have bubbling foam coming out of your chest, we know there's a hole in your lung. That's probably the only instances it matters. These are the phases that you'll go through. I sense something is wrong sometimes. That means I need to sit down before I fall down. Then you go through loss of consciousness. Then a tonic, like tone, like muscle tone. Clonic is like the clock. So if all I was is I went into the tonic phase and then postictal, this would be what I look like. If I had clonic aspects, it would be this, the rhythmic part. So you have the tone and the clock, the tonic-clonic experience.
Now, when people wake up from the post-ictal state, I know that there can be a myriad of things that happen. What's the most common?
Confusion.
Confusion, okay. Because I know people get real angry sometimes.
Sometimes. I've only fought one post-seizure patient. I was always like, yeah, I get, they're always like, oh, they can be so angry. I'm like, they're not usually angry. Usually they're just tired and confused. No, I had one that was just mean, like for sure. But yeah, so make sure you know this. The number one key to whether or not a person had a seizure isn't the tonic, isn't the clonic, or the loss of consciousness necessarily. It's the postictal phase. The postictal phase is the strongest indicator that a person had a seizure. What this looks like is I get a weird smell, a weird sense, something's wrong. I either go into a tonic or tonic-clonic phase or an absent phase, whatever the type of seizure I'm having. And then when the storm calms down, like an old computer rebooting, I've got a period of time there where I'm not all the way back. And that's the postictal phase. It can be 5 minutes, it can be 5 hours. It changes. It's not usually more than 10 or 15 minutes, but it can be very prolonged. But one of the biggest distinctions that you'll have is syncope or seizure. That's one of the biggest questions you'll have trouble determining. If somebody vagals down like they're trying to have them a daily constitution on the John today, right? If they put too much pressure on that vagus nerve, it can make them pass out because it lowered their heart rate or blood pressure. Well, guess what? When you vagal out, when you have vasovagal sympathy, syncope, vasovagal empathy, I don't know. When you have a syncopal episode, it's a momentary hypoxia of the brain, and it can make you shake. People call out for seizures all the time when really it was just syncope. The question is, how do I know the difference? One of them indicates one thing, one of them indicates the other. And the answer is, were they confused afterwards? Right? So Landon, I just want you to fake like you passed out, and then immediately when I touch you, you go back into normal behavior, okay? I'm hanging out with you. Yeah, I can't wait to play racquetball. He goes out, and I'm like, whoa, hey, buddy. Whoa, hey, what's your name?
Hey, it's Landon.
Okay, 0 postictal phase. He was out, and now he's back. And so a lot of times I'll come in, you know, my husband, he had a seizure and he fell and he hit the ground or whatever, and I come over, I say, okay, when you ran over to him, how did he seem? Like, seemed weird or whatever. I said, was he confused and stuff? And he's like, not really. He just said that his arm hurt and stuff. I'm like, okay, I think he had a syncopal episode. I don't think he had a seizure, because postictal phase is the rebooting of the brain coming back online. That's one of the biggest keys.
Wait, so which one, is one of them you said, like, they go out and then they come back and then it's like they didn't even like, pass out, basically? Which one is that?
We have 2 types of seizures, generalized and focal. Generalized you're not conscious for, and they can either be tonic-clonic shaking or 0 movement absence.
For the focal one, right?
No? Generalized seizures are either shaking tonic-clonic or 0 movement at all absence. You're not conscious for any of them. Focal is when a very specific part of your brain is seizing, and you can be conscious for that. It might just be a twitching face or a crooked finger, or your left leg won't stop kicking, but it's very specific. They can have postictal phases, but it's far less likely, because postictal is usually the result of a generalized seizure taking over. Sebastian, I got you. Mr. Harris, what's up? Do you remember your thing?
Yeah, you and I were called out for 2 seizures where the patient clearly identified themselves. They clearly said at what scene in the Marvel movie they were watching their seizure began and stuff. And so we were like, well, that's not a postictal phase, right? That's
Right.
Like, they themselves were able to, not only they knew they were having the seizure, so it was like that pseudo seizure, but that they could just clearly articulate the whole thing with no confusion whatsoever. So
Right.
also,
Yeah, and I'm thinking at that point, I'm like, okay, I don't think that was a generalized seizure. Sebastian.
So would like how long they were unconscious for lead you in a direction of like if it was a syncope episode or like an actual seizure? Like would that have any play in it or no?
Most seizures you encounter are going to be generalized tonic-clonic. They're obvious. Everyone around can see it. So I would answer your question by saying the time at which they're unresponsive can matter, only in the sense that syncope is instant. Like, if you wake up by the time you hit the ground, that probably wasn't a seizure. That was a syncopal episode. Syncope is seconds. Seizures could be much longer. More to the point, you know how we have status asthmaticus? What is status asthmaticus?
You don't react to the medication. Right?
You don't get better, right? Like you're refractory to albuterol and atrovent. There's also a profoundly deadly situation called status epilepticus. Status epilepticus is a very deadly presentation for seizures. Status epilepticus is defined by one of two things, either a prolonged seizure or two seizures back to back without you ever becoming fully lucid. So I have a seizure, I come out of that seizure, but I'm postictal. I don't come all the way back around until I have another. That's status epilepticus. If you're not having periods between seizures where you come back, the mortality rate for that, if you can't fix it, is huge. So,
Become deadly. Is it just not able
because,
to breathe
let me put it to you like this. Everyone should go to the hospital for their first seizure because it might mean you've got a tumor on your brain. Now, most seizures are idiopathic. We don't know what's causing them. You go to the hospital, they scan your brain, and they're like, oh, you look fine. Call me back again if you have another seizure. And if you do, they take your license and they treat you for seizure medications for 2 years. They never even found anything. You just had 2 seizures, now they treat you. But why we push transport, especially for the first one, is because it could be a deadly sign. Your brain is goofing up. Something could be very, very wrong. So status epilepticus is deadly by nature because if you are having something wrong with your brain that is causing a seizure and you're never becoming conscious in between them, something is super wrong. Now, specifically, status epilepticus is associated with an increased mortality if it's refractory to treatment. No matter all the benzos I give or the threshold reduce or increasers, if the meds aren't working, dude, status is going to kill you. You're going to seize and never come back. But just make sure that you know as clinicians, the status epilepticus is these prolonged seizures. The book says it can be upwards of 5 to 30 minutes. Like most seizures are over in seconds. I would say most seizures end in less than 2 minutes. But I'm not going to call somebody status if they're in 5. Mostly for me, it's the refractory condition. Or you never come all the way back before your next seizure. That's a major issue. We give Versed for seizures as paramedics. Most people stop seizing before the med ever gets in them. Make sure you know the difference between decorticate towards the core and decerebrate, which is away.
Cerebral is the one that's right before death. Which one was it again?
Good job. Yeah, and GCS, because if you think about it, if you're trying to block a punch, you're going to defend yourself. That's like the last thing you can do before you can't. If you're not even trying to defend yourself, you have this kind of posturing, then you're one rung lower on the list, right? Trismus, Merry Christmas, everyone. That's jaw clenching. Make sure you know that vocab word. It's going to pop up. No matter what happens, I'm definitely ending in the next 10 minutes, gang. When we talk about pseudo-seizures, be careful saying, hey, whoa, they're faking it and they're faking it. You're going to hear this all the time in the field. People are like trying to determine whether or not this is a real seizure or not. I don't super care. I don't care. I got to write a report either way, and I'm happy to give out meds, so it don't bother me, right? So I tell patients all the time, I say, hey, I'm sorry you had a seizure today. The better you can communicate with me, the better I can make you feel. Like that's if I'm thinking they are faking it, but I don't care. Hey.
What did you say trismus is?
Jaw clenched. Clenched jaw can definitely be an indicator of a seizure. A person isn't going to be having a diabetic emergency and a clenched jaw. That makes no sense. It's an indication of brain activity, essentially, overactivity. I always used to tell the medics this who did treat seizures in the field. I say, look, even if you think they're faking, if they bit their tongue or peed themselves, you win a prize. If you're that committed to the role that you're faking a seizure and then you wet yourself, I'm going to give you the feel-good medicine. You win. You win. But I think people try way too hard to prove that the seizures are fake, and I'm just like, it's not your versed, send it. What are you talking about? Take care of them. Now you can test this in two ways. You can do the arm drop test. Does anybody in here know the arm drop test? Yeah? Okay, so if you are, if you're actually unconscious and you fail my arm drop test, what happens? If you're actually unconscious, your arm falls. If you're faking it, and I'm like, all right, let's see. And you'll have to tell people sometimes. You're like, if they're having a seizure, both their arms are going to stick straight up. And then they do, and you're like, yeah. Right? Now, I don't treat them different. I'm not like, oh, you're faking, rah. But now I know where we're at, right? Now, I do the
Give, like, pain meds and all that
I
kind of
would not
stuff.
give them Versed. That's right. I would ease up on that. Yep. Yeah, you lost. Now, one thing I recommend is what we call the corneal reflex test. Now, you don't do it this way, but I just think these are great pictures.
Where'd you find that? What a horrible website.
It's a very specific part of Reddit.
I told you eye stuff makes me
I know, I did it for you.
like. Yeah, I bet you did.
I do. So I can't remember what I practiced with the last time, but this is what corneal reflex test is. Haley, close your eyes. I think it was. Okay. Right, okay. Go ahead. I'm going to test to see if she's faking. So this is a corneal reflex test. I just say, hey, look, sweetie, we're going to take care of you. I got to check your blood pressure, and I got to, right? That's it. I just lightly, it's not truthfully a corneal reflex test. Corneal reflex test is a doctor takes like a long medical Q-tip and then taps your cornea just like this. And he's testing for your neurological function. So I call it a corneal reflex test in my PCR, and it is like foolproof. If somebody is faking it and you just lightly tap on their eye, buddy, even when they know it's coming, it'll be so jarring. You don't stick your finger deep in there, but you just tap it. And so very often I'll see somebody and they're like, I'm like, I don't know if there's a real seizure or not. And I say, hey, look, we're going to check your pulse soon, ma'am. I just want to boop. And they're like, derp. You know, they really react to it. I'm like, okay, I see what bucket we're in. It's okay. Look, we're going to take care of you. The big thing for me is I'm going to move you soon. And if you had a real seizure, I know now we're in danger of moving you. I want to kind of wait and get things settled. But if you're faking it, I'm like, hey, take it down a notch. You don't flip my stretcher over, you know.
Heard that, like if they're having a seizure and you touch their eye wouldn't like react.
Yeah, and you can test it. If you're going to bed next to somebody tonight, if they're really asleep and you touch it, nothing will happen. But if they're awake, they'll react. So if they're in a generalized seizure, absent or tonic-clonic, they will not be able to react to that stimulus. Febrile seizures is an important concept to understand. Adults don't have febrile seizures, pediatrics do. I don't know where the age cutoff is, but it's probably around 8. Put very simply, when you're young, you have a very hard time regulating your thermal response. So generally you'll see this. Here's where students struggle. It's not high temperatures that cause seizures in pediatrics. It's the sudden change. 99 out of 100 times, it's going to be a sudden change high, but it can happen for a sudden change low, which is why I say, hey, if you got a kid with a fever and you're going outside, throw a sheet over him. Let him kind of insulate himself. Because you can definitely have an experience where you go from hot to cold and they have a seizure. So again, when your test question comes, it's going to make sure that you know that it's the sudden change, not a high temperature. So the question will be something like, which of the following patients should you suspect is most likely to experience a febrile seizure? 65-year-old man with COPD, a 2-year-old kid who has a very high temperature, or a 3-year-old kid who had a sudden spike in his temperature, and that's the one. The change is what causes the dramatic effect, and it'll throw him into a seizure. Now, so therefore, any kid that has a fever is very likely or at risk for a febrile seizure. This comes with usually either ear infections or teething, which also can cause a inflammatory response. So if I got a kid and they're like, I don't know what happened, he turned blue and he shook, I thought he was dying, I'm like, okay, how old is he? And they're like, oh, about 8 months. I said, Mama, is he teething? Yeah, he's teething like crazy. I'm like, okay, well, it could be a big scary thing, but it's also sometimes just teething. Let's check his temperature. Yeah, he's got a 102. My guess is he was teething. It caused an inflammatory response, and then he seized. So we're going to take him to the hospital so they can scan his brain, but that's probably what happened, Mom. Or he's 4 years old, and then he's just like, yeah, he's had this yellow leaking out of his ear, or the baby keeps touching his ears. He's been running a fever. Today he seized. I'm like, yeah, it's probably the infection that has changed his temperature all of a sudden, and that's caused a seizure. Make sure you know your eye stuff. This part I don't think is in the chapter, but I want it to be, so we're going to make it there. You got to differentiate meiosis, mydriasis, and anisocoria. Now, my hope is based on the groundwork we've laid, you can already do that. A new one might be nystagmus. That's the shaking eye. Repetitive, uncontrolled movements, nystagmus.
But isn't there also a condition, I forgot what it's called, astigmatism, where I can just move sometimes?
Astigmatism is like a misshapen.
Is it this?
It means I have to wear glasses because I have astigmatism.
Oh.
Nystagmus is the shaking. That's all right.
When I'm driving at night, it's got it's like,
Is it like those ads where you see like, here's the glasses before, it's just
One thing that should be on that slide is something I don't know, which is the number one causes of nystagmus. I don't know what causes nystagmus.
There was a slide ICP and Cushing.
There you go. That makes sense. My guess was going to be profound brain issues, and I see it in here. I've been pretty wasted, and I've never, I don't know, whatever.
You don't know that you're having nystagmus.
Oh, I know. A man knows his own stagmuses. Now, AEIOU tips is what you're going to see in the book, and it is something that you should be familiar with. You know how you walk up and somebody's confused and you're immediately like, what's your sugar, what's your oxygen, or what? You're working through AEIOU tips, you just don't know it yet. Now, you might want to know it or be able to have some semblance of what these mean. I don't use that. I use hot sacks. You know Mr. Farron prefers a hot sack. Not only is it easier to remember because it's funnier, but it's also shorter. So my recommendation is that as a clinician, you know hot sack. But rest assured you won't see it on the registry, but you may get a question that says something like, the E in AEIOU tips stands for, I don't even remember. There you go. It's not in hot sacks, so I don't know. Thanks for staying, gang. Like I said, I'm going to take a look at this video. I'll post it up on YouTube, probably send an email out and say, hey, here's this, and I am interested in your feedback, especially for sound quality and stuff. I'm a little curious about how it picks up other people or not. That's why I tried to get close if they're talking, but we'll see how that goes. So.
I saw it, and then like you repeated some stuff. Kind of talking about